Key features of lung scar cancer. Lung scar cancer was first reported by Friedrich in 1939. Lung scar cancer originates from scar tissues in the lung and periphery locations. Lung scar cancer has no specific symptoms, and the tumors always overlap existing scar tissues. Lung scar cancer can be easily misdiagnosed as an old lesion, delaying treatment. Furthermore, it has poor prognosis because of metastasis from relatively small lesions. So here we see the CT image of the lower lobe of the right lung. This lesion is a spiculated lesion, and there is a gradual enlargement of the peripheral lesion here in this image. The lesion was confirmed as adenocarcinoma by histopathology. Discussion. Lung scar cancer was first reported by Friedrich in 1939. Most lesions are smaller than 3 cm and localized to the periphery of the upper lobe of the lungs. Lung scar cancer shows male predominance and is mainly adenocarcinoma or peripheral lung cancer. In the case of adenocarcinoma, fibrosis or scarring may be present at the center of the tumor. Intensive fibrotic degeneration and carbon powder decomposition is visible on the cut surface. Adenocarcinomatous cells are arranged in small nests or a single layer. Sometimes a few malignant cells are localized to the interlobar pleura or subpleural area. Lung scar cancers tend to show early lymph node metastasis and small vessel invasion, resulting in a lower 5-year survival rate, approximately 5%, than the general 5-year survival rate of adenocarcinomas is 22%, and adenosquamous carcinomas is 28%. Therefore, lung scar cancer should be suspected when a new lesion emerges in a lung scar or a focal scar shows enlargement in follow-up. Here we see these lesions with spiculated borders are getting larger and larger on the follow-up scans. Lung scars may occur secondary to tuberculosis, bronchiectasis, pulmonary abscess, organized pneumonia, trauma or infection, with tuberculosis being the most common cause. The pathogenesis of lung scar cancer is not clear. It could result from chronic inflammation of a lung scar, and repeated injury and repair process over a long period stimulates bronchial and alveolar epithelium, ultimately causing atypical hyperplasia or canceration of focal lesions. Fibrosis can disturb or block lymphatics drainage and result in pooling of cancer cells in the scar, causing more extensive vascular and lymphatic seeding in scar cancer than in the regular adenocarcinoma or squamous cell carcinoma. Lung scar cancers tend to occur at the predilection sites of lung tuberculosis. Calcification and satellite opacification are common CT features of pulmonary tuberculosis and generally regarded as benign signs. In the present study, these features were not significantly different between the lung scar cancer and the non-lung scar cancer images. These results could be explained by the fact that the lung scar cancers are mostly originated from old tuberculous lesions. Therefore, regular follow-up of scar tissue lesions is advisable because of the possibility of malignant transformation. Some studies showed that benign lesions often have an irregular or polygonal shape and long spiculation border. We found that both lung scar cancers and non-lung scar cancers manifested an irregular or polygonal shape, long spiculation, border, and pleural retraction. Therefore, these features have little diagnostic value. Alveolar structure collapse, local organization, or other factors in lung scar cancers may cause focal tissue injury, fibrosis, shrinkage, and retraction of adjacent structures, resulting in the irregular shape and long spiculation border of such tumors. Pleural indentation appears when the pleura is retracted by fibrosis. Fibrosis stimulated by cancerous tissues may form a lung scar, which may look similar to lung scar cancer in CT images and confuse diagnosis. Our findings show that lung scar tissue formation preceded canceration in all cases. These findings suggest the importance of regular follow-up of lung scars showing vessel convergence in CT images. Connective tissue hyperplasia is promoted by scar tissue formation and may produce air cavities. Lung scar cancers originates in bronchiolar or alveolar epithelium. Vacuolation occurs when partially aerated lung tissue is not replaced by tumorous tissue. It may also form as a result of overlay air-filled alveolar cavities blocked by tumorous invasion. The spread of tumorous cells in surrounding lung tissue can be manifested as ground glass opacification in CT images when these cells do not completely occupy the alveolar cavities. Ground glass opacification can be caused by inflammation, but the borders of the inflammatory lesions are obscured, whereas those of lung scar cancers are well defined. Recent studies have indicated that vacuolation and surrounding ground glass opacification can help to differentiate between benign and malignant lesions. Since these features are less common in non-lung scar cancer images, they can be helpful in lung scar cancer diagnosis. Well-defined ground glass opacities surrounding previously existing lung scar tissues can be considered as the manifestation of early-stage lung scar cancers. These well-defined ground glass opacities may solidify gradually if no early intervention is taken. Most lung scar cancers are adenocarcinomas, and their emergence and development are similar to those of adenocarcinomas. We observed overlaps between lung scar tissues and lung scar cancer on CT images. Thus, lung scar cancer diagnosis is very difficult based on a single CT image. Radiologists may misdiagnose early-stage lung scar cancers as old lesions if sequential CT images are not examined. The differential diagnosis of lung scar cancer includes recurrent pulmonary tuberculosis and pneumonia. Scar tissue change such as enlargement, speculation, and surrounding ground glass opacification associated with a well-defined border in follow-up CT image should be considered as indication of lung scar cancers. These are the CT images of the apex of the right lung. A speculation is visible in the initial image. The lesion gradually enlarges in the follow-up image and shows shows surrounding ground glass opacification. Here another lesion. These are the CT images of the apex of the right lung obtained in the lung window and in the mediastinal window. The lesion in the initial image gradually enlarges over the 3-year follow-up and shows small ground glass opacification. Here we see another lesion here. The CT image of the upper lobe of the left lung obtained in these lung windows, and here we see that the lesion is getting bigger and bigger and shows calcification in follow-up images. Thank you for listening.